For our next talk, it is my pleasure to welcome our next speaker, Dr. Anita Borges. Dr. Borges does not need any introduction to this audience. We have all heard her speak at multiple forums on a variety of topics. She is regarded as the last word in histo and oncopathology in India. She is a speaker of repute, an acclaimed author, and a recipient of several prestigious awards. I would like to invite Dr. Borges on stage. She is the Vice President of the International Academy of Pathologists Asia. She is the Chairman of the Accreditation Committee of NABL and the Dean of the Indian Medical College of Pathologists. She is going to speak on a very interesting topic today, practicing surgical pathology in Kalyug. Over to ma'am.
Thank you very much. That was a very generous introduction. Now, you know, when you're asked to speak and you have reached my age, you cannot compete with youngsters with regard to what's the most recent, what is technologically happening in the world, etc. So what do you resort to? You resort to philosophy. And people forgive you at this age, you know, when you decide that you want to talk on a philosophical subject. So I decided, no, that's not my, while they get it up, when Prashant called me and said, you know, that we would like you to give a talk at this, at the GAPM, I racked my brains a little bit, and I thought, why not have a catchy title? And then I came up with practicing surgical pathology in Kalyug. And you might say, why practicing surgical pathology in Kalyug? Well, I'm sure I don't need to tell this audience that we are in Kalyug. Yes? And I have practiced surgical pathology for the last 40 years. And since Kalyug has stretched from something like 5,000 years ago, and it will continue for another whole lot of millennia, I am practicing pathology in Kalyug. And I thought that we might take a look at what actually are these features or the criteria that people apply to Kalyug, and see whether the way that we practice our profession actually conform to what the ancients, you know, the Puranas and things actually said about Kalyug. That's me up there. It doesn't seem to me that I'm sorry. Slide, and it says surgical pathology in the age of Kali, because that's what Kalyug is all about. And I'm going to give you some reflections on 40 years. I have been a pathologist for 40 years, practicing pathology in this age of Kali, and maybe some thoughts as to what I think that the future will bring. Every one of us knows this Indian cycle of time, right? I don't have to tell this audience, because this audience knows exactly what these yugas are. And we are certainly not in Satya Yug. I think everybody knows that. We are in Kaliyug, and at the end of this Kalyug, which is really 4,000 and oh no, it's more than that, 43,000 years long, we will once again go to Satya Yug. And now if you just look and see what, you just have to Google it on the internet. Not that I'm a great, a great philosopher who knows a lot about all, the Vedic things and before the Vedas in the Puranas. We say that we're living in the age of Kali, and we are all rushing to our perdition. That's the end of the world. And they say some things about Kalyug. They say rulers will become unreasonable. They will levy taxes unfairly. Do you think they were talking about demonetization? I don't know. Yeah, people, it is said, will start migrating, seeking countries where wheat and barley form the staple food. And you know what is happening to our intelligentsia, or so-called. They're all rushing off to the USA, where people eat wheat and barley. They don't eat rice like we eat in this part of the world. But the funniest thing that I found over there, and it seems like a prediction, that ready-cooked food will be on sale. That means people will not be eating food that they cook at home. So do you think that the ancients actually foresaw fast food? Maybe they did. But the thing that really bothered me was this last thing, and that is gurus will not be revered. Now that means two things to me. Either that the students or the shishyas have become disrespectful of their gurus, or the other way about, that gurus no longer deserve respect from their shishyas. And I think that we ought to take a little heed of this last prediction of what can happen or what will happen in Kalyug. But there are some defining features. Okay, and you see, I've just taken some of them, and I think all of you should just think about it and see in our own profession and of course in our lives whether any of these apply. This is what was said that would happen in Kalyug, and that is things would just move extremely rapidly. And they say that speed is really one of the most defining features of Kalyug. In fact, we are rushing. We are rushing to perdition, right? And you know what speed does. Speed is the enemy of reflection. Reflection meaning that you thought, where you sit and think about what it is that you are doing. The next thing was greed. Greed, which is the enemy of truth and compassion. When you're greedy, you don't really worry about what's happening to anybody else. It's all about what I want and not about what somebody else needs, okay? Then there's expediency. You know, expediency is just do something for the sake of doing it, and just do it because that's something that we can do. And it's to a lot to do with the chalta hai attitude as well. So expediency, which is the enemy of stability, and we are now chasing the ephemeral, which is the enemy of substance. And what is the ephemeral? The latest fad that comes out, whether it is in fashions or it's smartphones or what have you. You just have to think in our own profession. We have gone through fad after fad after fad. And finally, of course, there is the ego, which is the enemy of selflessness. Now, these are not things that I am saying about Kalyug. This is what has been said about Kalyug, and it has been recorded in the ancient texts. And I think it's worth considering this in the light of things that have happened or are happening in the world today. And since I have worked in this field for 40 years, I thought it's as well to ponder on these questions and see whether they apply not just to life in general, but to our profession in particular. I think that if I had to define what kind of age we are living in, I would say we are living in the age of instant gratification. I want something here, I want it now, and I want it as soon as possible. And all of you who have children will know exactly what I mean. And that is what Kalyug is all about. But Kalyug is not just about bad things. Kalyug is about things happening rapidly, advancing rapidly, things that we call progress. And yes, there have been a lot of advances that have taken place over the last 40 years. You can see here that there is automation, which when I was a young student, there was a certain amount of automation. But now, everything is automated. Whatever you can think of. Perhaps the only thing that has not yet been automated is our histopathology lab, right? Where people are still sitting there and cutting sections. But anything else, all processes have been automated. precision in diagnosis. Where we didn't know much about certain things before, now we have lots of ways. Income was just about coming up when I was training in pathology. Now we have not only, and I'm talking a lot about surgical pathology, we have so many different tests that help you to prevent diseases from actually occurring, early diagnosis and so on. And you have predictive pathology, and we'll talk a little bit about that. And as far as histopathology is concerned, once upon a time there was macroscopic imaging. We relied a lot about how something looked to the naked eye. Then, of course, you all know that microscopic imaging was there, and yes, we all use the microscope for our daily, in our daily profession, but that's now becoming more and more refined and more precise by the use of molecular imaging. And what do we mean by molecular imaging? Meaning we're looking beyond just morphological features. We're looking at molecules in tissues by probing those tissues, say with antibodies, or probing the tissues to look for nucleotides, that's DNA and RNA in tissues, by using complementary probes, etc. So we are imaging tissues much, much better now in the field in which I have been working before. And this is quite apart from doing molecular tests on tissues, but not under the microscope. Okay, so let's talk a little bit about the wonders of what has happened over the last 40 years, and then we will look at whether these wonders are really as wonderful as we thought that they were. Now, you know that here, this is small tissue, big diagnosis. Today, nobody gives us open biopsies where it can be helped. Okay, we're getting these smaller and smaller biopsies, and you heard a little bit about needle aspiration cytology and needle core biopsies, and that's become the order of the day. And you see there Sixten Franzen, who somewhere in the 1960s got that gun, the cytology gun, and the world hasn't been the same again, because now anything and everything that's a lump is needled, either with I think there is a bit of an echo. Is there an echo? I can hear it in my ears. So can you turn this down a little? There's too much of an echo. Yeah. So you either needle it for aspiration cytology, or you needle it to get a core. And I just want you to look at the evolution of cytology, because, as I will show you a little later, I'm not so sure about the future of cytology. It came with a bang, and you know that cytology was more or less invented by George Papanicolaou. But look here, there was a strong diagnostic presence in clinical medicine in the late 20th century. We are now in the 21st century. Why? Because it was simple, it was safe, it was a quick method, and this FNAC replaced open biopsy for many lesions, whether neoplastic or non-neoplastic. And you heard about how you can make a good diagnosis of mycobacterial disease by sticking in a needle and making smears in which you see granulomas that are either necrotic or non-necrotic, or the master class that you just heard. And cytopathology services then got separated from pathology services. And you know that there are some major institutions in this country which they are not integrated services at all. You have a separate cytopathology department that doesn't see any histopathology, and vice versa. I need not mention to you which they are. And these cytopathology departments got dedicated staff. And all of you know, right from George Papanicolaou's time, that cytopathology was started and integrated with the gynecology departments. And even in our own Indian Academy of Cytology, there were any number of gynecologists. Now, you can count on the fingers of one hand the number of gynecologists that there are in the Indian Academy of Cytology. And as they get older and older, and some of them have passed on, there are no more gynecologists who are in the Indian Academy of Cytology. So the gynecologists went out, and of course the cytopathologists came in. But very soon there was trouble in paradise. I like this picture. You know why I like this picture? Because it shows Adam and Eve who lived in paradise, yeah, and they were driven out of paradise because of the sin that Eve tempted Adam to eat of the forbidden fruit, which was the apple. And then the angel of God came down and drove them out of paradise because he said, sorry, you don't deserve to be in this Eden. But why do I like this picture? Because you see what the angel is holding? The angel is holding a very pointed sword. So what is this pointed sword that I think is going to make a big difference in the Eden or that paradise of cytology? And I think that it is the needle core biopsy. And we today have the decline of needle aspiration cytology in most places in the West, and I have no doubt that what happens in the West is very soon going to follow suit in our country. And the reason is that we have now good cores for core needle biopsy. Lesions are getting smaller and smaller, particularly in places like the sites like the breast, where you have an increase in screen or image-detected lesions at all sites. Incidentalomas are being found. And the radiologists and the ultrasonologists are performing these biopsies. Now, they were not brought up on doing needle aspiration cytology. They have taken to these needle core biopsies. They see the needle better. They're able to take these cores. They don't have to learn techniques of smearing and making good cytology smears. So they are doing needle core biopsies all of the time. And if you ask a pathologist, what would he prefer, a needle aspiration cytology to report on or a core needle biopsy? I think most pathologists, if you're not only doing cytopathology, would say that I'm very comfortable looking at a needle core biopsy rather than doing just an FNAC. Some of them may say that I would like both so I can have some kind of complementarity. And after all, histopathology is still the gold standard. Nobody will tell you that cytopathology is the gold standard. There seems to be a greater accuracy in needle core biopsies of diagnosis and grading. And what is the real strength is that on a core biopsy, on any histopathology, it's easier to apply ancillary techniques. And of course, if you want to go back and review something, it's so much easier, particularly if you want to do additional tests on it, to get this archival block out, and so archival retrieval is excellent. So, what do I think the future of cytology is going to be? I think there will be greater use of immunohistochemistry. There will be a gradual replacement of needle aspiration cytology by core needle biopsy, and that, by the way, is a picture of George Papanicolaou. Cervicovaginal cytology may become extinct, and you might ask me, why? It's because we now have a vaccine for HPV, and HPV is the main cause of cervical cytology for cervical squamous cancer, and that's what we essentially do cervicovaginal cytology for. We don't do it for endometrial carcinomas or ovarian carcinomas or some rare types of vaginal melanomas or something. We're doing it to detect squamous carcinoma of the cervix. Now, if we are going to get patients the public who are going to be vaccinated against HPV, and that's not a dream, it is a reality in some parts of the world, well, cervicovaginal cytology may become extinct. Techniques which are currently used for collection of material for cytology, that means aspiration, may not be used now to make aspiration smears. They may be utilized for molecular testing, which is quite a different thing from doing actually diagnostic smear cytology. So you can use the same technique, aspiration, for doing something else. Just anyone who goes and reads the cytology journals, put your hand on your heart and swear whether these, think about it, are the journals actually sort of getting thinner and thinner? Of course they are, because there's hardly anything but case reports in most of the cytology journals. And that most of them are published from the West. So you see, cytology is taking a back seat now to needle aspiration, core needle biopsy. And cytological diagnosis as we know it, as we understand it today, it's a prediction that I'm making, will slowly fade away. And I was just reading the other day in the British Medical Journal that posts for cytotechnologists are being done away with in the UK because there just isn't enough cytology for them to do. And so, will the academic departments of cytology, as we know them, will they survive? Well, this is my prediction for the future of cytology. This is what is going to replace cytology, and it is so vital. Why? Because we can do immunohistochemistry on it, okay? And that's one of the big changes that I have seen in my lifetime. Immunohistochemistry, which wasn't even on the scene when I was training until I went to the United States, and there was just some early work that was going on immunohistochemistry. We used to call it immunoperoxidase in those good old days, has now been replaced. I mean, it's like a special stain. Almost every big department that is doing diagnostic work, surgical pathology, has immunohistochemistry in one way or another. And you are looking at molecular antigens in tissues to be able to help you in your diagnosis, and you do it either by immunohistochemistry or you do it by in situ hybridization. And it all started with Albert Kuhns, and you know that he was the father of immunofluorescence, and he was the first to show pneumococcal antigen, and you can see that he did this in 1942. So from that time onwards, immune methods of diagnosis applied to tissues have been going on. Now, of course, we have immunohistochemistry, and there have been advances in immunohistochemistry, and those advances have been fueled by the fact that we can produce so many antibodies by the hybridoma technique. And these two gentlemen over here, Kohler and Milstein, got their Nobel Prize in 1984 for developing this hybridoma technique. And now you can produce antibodies by the gallon so that you can use them for a whole lot of diagnostic tests, not just in surgical pathology. I'm sure you know that you use them in serology all of the time. And this is just a graph to show the exponential rise of the number of papers that have been published in pathology. You see that after the early 1980s, it's more than a logarithmic growth. It's exponential. In the pathology literature, all with some immunohistochemistry in it, and this was only as far as 2006. No doubt that this curve, it's not a curve, it's a line, will just be steeper and steeper. And if you look at our own data, you can see whether it's Memorial Sloan Kettering, which is the lower graph, or my own lab, which is SRL Diagnostics, you can see that the number of cases that we actually access, which is the lower bar, hasn't changed much over the years. But look at the exponential rise of immunohistochemistry. So same number of accessions, but look at the amount of immunohistochemistry that we are doing. So immunohistochemistry is here to stay. It's not only of diagnostic value, it's a very good, previously when we just used to say round cell tumor, today we are more precise, and that has a lot of impact on how patients are treated, because they're treated in a much more precise manner, and these have led to some spectacular therapeutic advantages. There is predictive immunohistochemistry. Every time I do an ER or PR, what am I doing? I'm predicting whether or not that particular tumor will respond or not respond to hormonal manipulation. And then there are genetic abnormalities, which obviously have an effect. When there is a problem in the genes, it has an effect on the protein. And it's in immunohistochemistry, we're actually probing the protein with an antibody. And so by knowing whether the protein exists, is there or not there, I can actually indirectly say what is the genetic abnormality that has taken place in the genome. And just because I'm a histopathologist, I'm going to show you this case, without which I don't think that this patient would have got the treatment that she deserved. She was a very young lady. She was 18 years old, and she presented with severe respiratory distress in the mid-trimester of pregnancy. And she was found to have this huge left-sided pleural effusion and a big mass that was occupying almost the whole of the left side of the chest and was peeping out in the suprasternal notch. So one of the medical oncologists ordered a very, almost on an urgent basis, a biopsy of that, and rang me up and said, I want this report yesterday. I could understand why, because the patient was in respiratory distress. And I'll show all the pathologists in the audience. You can see that over here. It's a rosetting round cell tumor. Yes? Now, what is a rosetting round cell tumor that produces small round cells, homocyte rosettes, neural rosettes, young individuals, small blue cell tumor with neural type rosettes, soft tissues of the chest wall? There is only one diagnosis, right? And what's that diagnosis? Anybody can tell me that, I'm sure. And that is primitive neuroectodermal tumor, what we used to call the Askin-Rosai tumor. So I picked up the phone, called my friend, the medical oncologist, and I said, you have got a PNET, and he said, thank you very much, and he shot off his, what I call poison. You know that there are 3 treatments for cancer? Slash, burn, and poison, yeah? So he did whatever he had to do, and in the meantime, I set up the immunohistochemistry. And here was Vimentin. All right, it was positive. In those days, we used Vimentin. This is a long time ago. I don't have Vimentin in my lab anymore because I don't find it a useful antibody. And here is the CD99, which should have been positive in this tumor. And it's absolutely negative. Okay, it's negative. I know it looks positive over here because it's much too bright, but it is absolutely negative. It's day 1, day 2, day 3. In those days, we didn't have automation in our lab. And I swore at the technician, who's a very good technician. I said, you're doing something wrong. This is a primitive neuroectodermal tumor. By the 3rd day, it was negative, and he threatened to resign. So I said, oh, okay, if it is not a primitive neuroectodermal tumor, then what is it? And it was not synaptophysin positive, it was not desmin positive, so it was not a make a diagnosis even though the patient doesn't even know that he has what he has. And this was a warty growth on the ventral aspect of the shaft of the penis in a 69-year-old man. And you can see here it's a very spindly looking tumor. And most often you would think, okay, this is a spindle cell carcinoma, but it's not. It is a Kaposi sarcoma, and this is the HHV8 positive LANA. Okay, it is the latent nuclear antigen, and he was HIV positive. And today, here, we can look for the ALK translocation in lung cancer using an antibody, using an appropriate system. And you can see that this is what I mean, that you can infer that there is a genetic abnormality. And every time we show this ALK protein that is being expressed in this tumor, we know that there is an ALK translocation that has occurred in the tumor. You can show it this way, or you can show it by a break-apart FISH. So we are doing this molecular imaging on tumors. But we're doing something else as well, wonderful, and that is personalized medicine and predictive pathology. Once upon a time it was only these guys with their parrots, and anybody know who that little thing is in the little? That's awesome. Do you remember the name of that? Yes, the octopus who used to, predicted. Yes. So you see that the octopus was giving a hard time to the Swami as well as the parrots. Now we are giving a hard time to these people because we are doing predictive pathology. And personalized medicine is all about targets, and there are many, many targets in cancer, so much so that there is a science now, and that's called Theranostics. Therapy-related diagnostics, and wherever there is diagnostics, there are pathologists, okay? So you can find targets in tissues by immunohistochemistry or by molecular tests, genomic assays, or even by morphology, okay? And you know that the classic example is all over here. You see CD20. When we say that, rituximab can be given. Of course, breast cancer is the classical thing when we say ER, PR, or HER2, and so on and so forth. GIST, which is another, when we say CD117 or DOG1 positive, CD117, then this patient will probably respond to some form of imatinib or any one of the other small molecules. Then, of course, you can do this by PCR, or you can do it by now using the NGS machine or whatever. You can look for mutations. You can look for mutations in EGFR, in a host of different molecules, in lung cancer, in colon cancer, and it is all therapeutically relevant today. Once upon a time, it was a research subject. Now it is therapeutically relevant. And there's an algorithm that is being used now in the treatment of lung cancer. So much so that there is in the United States a group that calls themselves ACT Now, that is Accelerating Clinical Trials of Novel Oncological Pathways. And they're looking for these. Most of them, of course, work in the pharmaceutical industry or are supported by the pharmaceutical industry. And everybody now, mainly the hemato-oncologists, but a lot of other people, a lot of other clinicians are interested in checkpoint inhibitors. And these checkpoint inhibitors now, we are testing for them. We do the PD-1 or PD-L1 by the PD-L1 antibody, and we say that these are amenable to using the appropriate therapy that is targeted at these checkpoint inhibitors. Okay, what are the technological advances? Now this is all right, immunohistochemistry and so forth. We have automation, tissue microarrays, cocktails of antibodies, virtual, digital imaging, virtual. But let's just talk about histopathology. Look, this is the histopathology. It's not the future, it is now. I have seen one of these prototypes, okay? What does it do? It fixes tissues in 10 minutes, processes in 60 minutes, it embeds in 2 minutes. The section is ready in 5 minutes, and the stain and cover slip in 1 minute, okay? So, The total time elapsed is 2 to 4 hours from the receipt of the biopsy. You can have a report out. I've seen one of these, okay? You still probably need somebody to be there to actually cut the section, but it is all being done by a robot. So, look at our turnaround times. The turnaround times are going to be fantastic, right? Multiplex immunohistochemistry. On one slide, you can put so many antibodies, and we do it in our lab when we use PIN4. You can show both AMACAR and HMWCK in the same slide, and you can say whether or not there is or there is not a loss of the basement membrane, as well as AMACAR in the prostatic cancer cells. So, tissue microarrays. You take little bits of tissue and you don't have to use a lot of antibody to stay in so many slides. So you just put a whole lot of tissues and then you can do ERs, PRs and whatnot on about maybe 50 or 60 cases on the same block. So there is all sorts of weird and wonderful things that are happening. There's virtual microscopy, and I'm sure there are some labs in this country. They don't use it necessarily for diagnosis, but for teaching and for doing a lot of other quantitative things. I know Anand, the Diagnostics, has a virtual microscopy setup. Next generation sequencing, which we have, and this is the new nasha now, everybody talking about it. Liquid biopsies. So you don't have to biopsy a solid organ. You just take the blood of the patient who has a tumor and you look for RAS mutations, EGFR mutations, and whatever mutations you want, and it tells you not only about the primary tumor, but the mutations that might have evolved in the secondary tumor. So liquid biopsies is the new thing, new kid on the block. And through all of this runs this question of where is the evidence, all right? We have all of these huge advances that are taking place. And along with that, people have been asking, where is the evidence? Now, the impact of evidence-based medicine is, I think it has to be huge in surgical pathology. Why? Because, and this is what evidence-based medicine is, why? Because surgical pathology is a subjective thing. We all know that. We discussed a little about it in the morning. And somebody made this very interesting remark, and that is, how can it be possible that morphologic examination of devitalized human tissue that has been fixed in formalin, dehydrated, permeated with paraffin, sliced thinly and stained with biblical era colorizing agents, nothing has changed as far as H&E is concerned, covered in glue and sandwiched between glass, how can it be that this has any bearing on the clinical management and decisions made for the living patient? Meaning, this is such a subjective branch. Now, where is the quantitation in it? Quantitation is what is required to make a difference. Well, yes, if you're looking for quantitation, then evidence-based medicine is going to bypass anatomic pathology, because anatomic pathology is not easily given to quantitation. And when you look at the pyramid of evidence-based medicine, all of these observational, sort of literature, case series, retrospective reviews are not given much weightage in this whole thing of evidence-based medicine. You need meta-analysis, you need randomized trials, and obviously that's not available to surgical pathology. And everybody knows that there is a lot of inter and intra-observer variation. Yeah, so people have tried to minimize this. So today, which didn't exist when I started out, you have scoring systems and indices. You use it every day. Bloom, Richardson, Nottingham, prognostic index. You have minimal data sets. You have, the directors of anatomic pathology, the RCPath, they produce these data sets that should be used for grossing and reporting. And of course, you have standardized criteria for making diagnoses, something like the Shimada classification. And everybody knows this, the follicular variant of papillary thyroid carcinoma is one of my favorite things because I'm interested in head and neck pathology. Yeah, somebody decided to see whether FVPTC was how was it being diagnosed? What was the interobserver variation for FVPTC? And I just want you to pay attention. There were 15 cases given to 6 experts, as you can see over there. Then you can look at expert number 5. And what do you notice? Expert number 5, except for one case, which every expert called benign, except for that, expert number 5 called everything follicular variant of papillary thyroid carcinoma. And expert number 6 called everything benign, except for, I think, 2 that he called follicular variant of papillary thyroid carcinoma. And these are all experts. So how do you treat a patient? Obviously, it will depend on which expert you send the case to. So what should have been done at this time? And finally, it has been done. It was done, and this was in April of this year. JAMA actually published this. So all the experts and a lot more got together, and they have now decided that that is not a carcinoma at all, which should have been obvious to anybody who was looking at all this interobserver variation, that this is probably something that is very indolent, should not be called a carcinoma, and they are now calling it NIFTP, non-invasive follicular tumor with papillary thyroid carcinoma nuclei. And this is the way that evidence is built up in anatomic pathology. There are also people like Professor Marchevsky who are devoted to collecting evidence. And that is really something, by analyzing both prospective and retrospective data, which is what Sujay was talking about in the morning, looking to see as to whether what we are doing actually is impacting patients' treatment or their lives. And this is one of the trends, and I think a good trend, that has come up in the surgical pathology literature. Now, does anybody remember this? Anybody in the audience remembers Index Medicus? Yes? Yeah, and I say the yes people are all those with gray hair or no hair at all, yes? Because Index Medicus, the last Index Medicus was published in 1993. After that, there's no Index Medicus. Why? Because it has been replaced by Google Baba and, PubMed and all of this thing. So what does it mean that when we had to do Index Medicus, it took us such a long time even to write our theses, because we had to look painstakingly through the literature. But I do know something, that when we went painstakingly through the literature, we actually read it. And when we actually read it, we understood something that we were doing. Today, information just tumbles out of any site that you go to. And the biggest issue is you get it at such speed that I think this is true. Too much information is the plague of our times. And this morning, I think Sujay said it, he took the words out of my mouth. Knowledge is really what we seek, but insight, that is an understanding of what that information actually means, is rare in this firestorm. I mean, it's being thrown at you from so many places. And the GAPM meetings and IAPM meetings are also part of this information firestorm that is the internet. And as people say, we have an embarrassment of riches. Big data, lots of data. And I will only leave this with T.S. Eliot. What did he say? Where is the knowledge that is lost in information and the wisdom that is lost in knowledge? Okay, so that's... We're talking about speed. Everything must be done quicker and quicker. But I'll ask myself, will the report be more accurate for all the haste? Would we sleep better at night knowing that we were quicker? I doubt it. So, haste for the sake of haste, I don't think is wise. There's the old adage which may not be relevant today, although it is very relevant to me, and that is, haste makes waste. That's right. So let me go now to one of the problems that we see in this Kalyug. Okay? And here is the Indian scene. And I put this up here because it will resonate with a number of you. And that is gross examination of a specimen, which is basic histopathology or surgical pathology, or gross negligence. Okay? Everybody knows that we have data sets and there are certain things that we should do. That's what it's all about, minimizing errors. Now I'll tell you, anybody can tell me what is the pStage of this tumor. You can see that this is a colon cancer. It has gone through the muscle, but it is not in the fat, and there are no lymph nodes. So this is what we call modified Aslocola B1 N0. Now this same case, all right, another section on the same case. Is this Aslocola B1 N0? The answer is no. It's out into past the muscle. It is in the subserosa, so it's now Aslocola B2 N0. But if you take a third section and it goes through the right area, there you have a lymph node. So now it has become Aslocola C2. And imagine if you had that one section, just that one section, which is at the top left-hand side corner, what would this patient have received or not received? This patient would not have received any adjuvant treatment for his colon cancer. And believe you me, this is what happens almost every week in my consulting practice. We are sent things to stage after they have already been grossed. And I cannot stage this disease because it has been inadequately sectioned or enough lymph nodes have not been dissected from the specimen. So why do we have this very inadequate grossing in this? Why? Is it because pathologists don't know? Perhaps. Maybe they're not taught in the institutions. But you know, in my explanation, and I feel very ashamed to actually say it, and I have said it there, it's because there are such low charges for histopathology and such narrow profit margins due to unhealthy competition that people don't think that they should take the adequate number of sections. So many of these things are under-sectioned and the patient doesn't get the right. Now, why does this happen? Well, I think everybody has to examine their own consciences as to what is it that we are doing when we say that we are practicing surgical pathology as a living. So, can this be rectified by immunohistochemistry? Yeah, some diagnosis can, and I would say that panacea or a cure-all, yes, for those who do not have it, but no, I don't think immunohistochemistry is a panacea for those who do have immunohistochemistry. And why? Because I'm telling you, in this city, as it is in most parts of the world, where you charge for immunohistochemistry, there is overutilization of immunohistochemistry for commercial reasons and for defensive pathology. And much of that immunohistochemistry, at least in this country, has not been validated, it is not standardized, and there is no quality assurance. I do a little bit of teaching in Gujarat, and I know that many teaching hospitals, when I ask, they say, yes, we have immunohistochemistry. And when you get down to it, you know what that immunohistochemistry is? ER and PR and HER2. Yes, not much diagnostic immunohistochemistry, and that ER, PR, and HER2 is not undergoing any kind of quality assurance. And if you don't have that quality assurance, this is what can happen. And this is in Canada. And Canada is a highly developed Western country. And St. John's in Newfoundland was the head of department of that particular hospital had to step down because of what was discovered when a doctor's wife was found to have had her ER/PR read wrong, and she was treated in a way that she should not have been treated, all right? And she said that determined that Eastern Health, that is that particular hospital, not only made hundreds of mistakes with hormone receptor tests over an 8-year period, but was not even aware of it. Why? Because it had almost no quality control measures in place to govern the pathology's lab's work. So, in this wheel of time, wants, and it is a want, you want ER, PR, and HER2 before any diagnostic immunohistochemistry because it brings in revenue. So its wants often triumph over needs, that is, the patient's needs. Okay? Here is another thing. Everybody is now sending off stuff for MammaPrint and Oncotype DX. You know that? So many breast cancer patients are being asked to go and get this, Oncotype DX or MammaPrint. And when you actually see what it is that MammaPrint and Oncotype DX, what genes are actually being looked at, you will find that those genes represent ER, PR, HER2, and a proliferation index. So we could easily do that with ER, PR, HER2, and Ki67. But so many patients are being sent, and I leave you to imagine why these patients are being sent for Oncotype DX and MammaPrint. When there are so many articles that say that molecular profiling currently offers no more than tumor histopathology and basic immunohistochemistry. In fact, in the lower part says that on close scrutiny, 5 of the 7 largest studies on cancer prognosis say that this technology performs no better than flipping a coin, and the other 2 studies barely beat horoscopes. Big data which has not been adequately looked for a signal-to-noise ratio. Okay, that was a good thing that I heard this morning. So there are other advances that we see, and I will deal basically with market forces. Have you seen ads like this? They used to appear now and then in medical journals. Now they're full-page ads in the newspapers. Why? For genetic testing in newspapers. Okay, so who are these labs actually targeting? They're not targeting doctors who should know when the genetic tests are required and whether they will give the information that is. They are targeting patients. And why are they targeting patients? Because patients are desperate. And when there is desperation, then your doctor may be right, but your medicine may not be. Why? Because the doctor hasn't you may have some kind of drug that will be targeted to your thing. And I want you to look at this. Do you people use ASCO guidelines for reporting HER2? I hope you do, because that's what you're supposed to do. And here is the 2013 ASCO guidelines, and you see, I have circled it. You're supposed to read it in what is greater than 10% of tumors. I'm talking about the score 3, but it's the same thing for score 2 and score 1, which will adjust. But what was this in 2007? You had to read it in greater than 30% of cells. So now, in 2013, if you're going to read it in a lesser proportion of cells, then you have to ask yourself the question, why have they lowered this threshold? And I ask, who benefits? The patients or the market? Because obviously there is a drug that is given for anti-HER2. And if more patients take it because you have lowered the threshold, you know, when I was in medical college as a pathologist, what was the serum cholesterol level before which we used to start getting anxious? 256. What is it now? I don't know, because I never bothered to do my cholesterol. So what is it? 200? Oh, it's lower than that, okay? So why has it been lowered? Is there evidence? And has anybody gone to look at the evidence? Yes, there is evidence. So find out, no? Yeah, don't you think that the amount of statin that is being prescribed is huge because you have lowered the threshold? It's happened with diabetes, it's happened with cholesterol, it's happening with hypertension, okay? So who benefits, the patient or the market? And once again, wants often triumph over needs, and greed is often justified as progress. And I come to the last part of this, and that is reason and judgment. You know, reason means evidence. We have to collect evidence. And judgment means wisdom. When should we apply that reason? And therefore, I would say reason relates to the general and judgment to the particular. And this evidence-based pathology, as I told you, we are in surgical pathology is a subjective science. And therefore now, because of this evidence-based medicine, subspecialization has become the norm. In the UK and in the US, you have to subspecialize. A breast person cannot report on something that is not in his or her domain. It's very difficult to implement all over the world, but I have one other criticism, and that is people are being pushed to subspecialize before they have even understood what the subject is all about. So, too early specialization limits versatility and insight, and the people who are pushing for subspecialization have all been versatile, but now they're pushing subspecialization on those whose versatility is going to crimp their subsequent growth. And then everybody is being urged to do synoptic reporting, yeah, and it's checklists, and anybody who wants to read this, it's a very good book, Atul Lavande's Checklists. And it does prevent gross sins of omission, and is very good for standardization, or what I call homogenization. But I also say that it's a recipe for mediocrity, because when you have a form that you have to tick, you never look left and you never look right. You just tick what is over there, and it stops the process of thinking. So you must have checklists, but I do not believe that that's the only way of doing reporting. And I come now to judgment, and I will just say this, that we have rules, okay? And one rule is that thou shalt not kill. If you do, you will be punished. Do you punish everybody who kills? Yes or no? Oh, no, we don't, because the state kills in capital punishment, we kill in war, we kill in self-defense, and we don't get punished. So why don't we get punished? Because of the context, yes? The rule says, thou shalt not steal, and if you do, you will be punished. Here is the context. Hungry child caught stealing food. Punish or not to punish? So there is a context, yeah? And so I think that there is evidence-based medicine and there is real-world medicine. And here is one EBM guideline, and that is treatment of mild hypertension is a diuretic. And I'm just showing you this because context is so important, and we believe that evidence is all that we need. It isn't. And here is this woman who's middle-aged, she's heavy, she's osteoarthritic, she's recently widowed, she's never been hypertensive before. She lives in a chawl. I don't know whether you have chawls in here, but in Bombay we have. It's one of these places which doesn't have a bathroom or a loo in every block, okay? They have to use a common toilet, and they often have to come down to use it. So the toilet is Indian style and not on the same floor. So now what will you do? Will you give diuretic? That's the Cochrane report evidence. Will you? The answer is no. Can you imagine a woman with diuretic who's osteoarthritic, squatting, coming down steps? You wouldn't. You would give her an anxiolytic because she just lost her husband, she's widowed, and she's probably very, very anxious. So, what does it mean? That we have these issues also in pathology where the context is important. And I'll show you a case where a carcinoma is not a carcinoma. And here you are. All right, this is a woman who's being treated for infertility, and this is her endometrium. Because it's very thick, it was curetted. You're going to call this a carcinoma? I think in an 80-year-old woman or in a 60-year-old woman I would call this. Are you going to call it a carcinoma? And it was called a carcinoma, and this patient was going to have a uterus out. It is not a carcinoma. It is an atypical endometrial proliferation which is driven by unopposed estrogen, okay? And it does look like a carcinoma, but you're not going to treat this as a carcinoma. The context is important. She's a young woman, and you can revert this endometrium by hormonal manipulation, okay? Here is when a carcinoma is actually a lipoma, and you might think that I'm mad, but here it is. Excision on the mass of the palmar surface of the right hand of a 22-year-old recently married lady. She had a little child. She came to see me. She had this thing excised, and it was called syringocystadenocarcinoma. All right? Well, yes, it looks like a carcinoma. I don't think anybody in this audience is going to call this benign, but I called it a lipoma. You know why? Because on the same slide, there was a lipoma, and I found out that this patient had this thing for 12 years. So I asked the history, because it's not common to get syringocystadenocarcinoma in the palm of the hand. And this she had for 12 years. She had it excised because she was recently married, and her husband did not like to hold her hand with that lipoma on it, okay? And the pathologist described it as a yellow greasy nodule. The surgeon took it out as a palmar lipoma. But when he got his slide back, the pathologist saw, so he called it syringocystadenocarcinoma. Two pathologists called it syringocystadenocarcinoma because it's there, and that's why it's a syringocystadenocarcinoma. We had fingerprinting done on this because the patient was absolutely terrified that if she didn't believe me that if it was lipoma, she might actually die of this metastasizing. And fingerprinting showed that the thing on the top didn't belong to her and the lipoma actually did. Okay, so context is important. And here, it was referred to this morning. When something is a carcinoma, it doesn't look like a carcinoma, but it is, and this is verrucous carcinoma. You can get this biopsied I don't know how many times, and you'll still call it benign until you see the patient, and that's a verrucous carcinoma. So what is the future of pathology? I think that the future of pathology is exponential growth of information. It will just grow and grow, that it will be extracted from smaller and smaller quantities of tissue. Computer-based algorithms, we've heard about it in the morning, will require bioinformatics experts in every lab. And I think Anand Labs is way ahead of its time. Techs will evolve into robots with artificial intelligence. Sometimes I think they have artificial intelligence right now. And conferences like this and consultations will be held in cyberspace. So will tissue pathology as we know it survive? I think it will. I think the reports of the death of surgical pathology, as Mark Twain said, because somebody published his obituary before he actually died, and he said, reports of my death are greatly exaggerated. I believe what Juan Rosai also said. And he said, there is no technique in all of medicine that provides so much information so quickly and for such little cost as the H&E technique. As we say in our language, it is sundar, sasta, and tikau. Yes? And I'll show you this. This is a clear cell renal cell carcinoma. That's all you need to say. And when you say that, see what out of histopathology you can get. Clear cell renal cell carcinoma, Furman grade 3. Yeah, you have, in that one sentence, you have given its potential for lymph node, lung, and bone metastasis. You have even told that clinician that there's rare regression of metastasis with removal of the primary. You know that the VHL function is abnormal, particularly on chromosome 3, and you know it will respond to anti-angiogenic agents, mTOR inhibitors, and TKIs, all without doing anything else, just doing histopathology and saying that it is a clear cell renal cell carcinoma. What could be more cost-effective than that? So all for the price of a histopathology report. So what will be the role of the pathologist, surgical pathologist? I think we have been traditionally the guardian of the paraffin block. Today, through that paraffin block, we have become contemporary guardians of the RNA, DNA, and protein. In fact, we have become chief consultant and chief information officer for our patients. And I say this, if as pathologists do not respond to these challenges, then we may end up like Sanskrit as a language. Historically essential, intellectually challenging, but no longer in dynamic evolution. So what have I learned over 40 years, ladies and gentlemen? A lot. I have learned that we must be clinicians first and last. That reason without judgment can be very dangerous. A good gross examination and a good H&E are worth their weight in gold. And the role of the surgical pathologist, of course, is changing very bewilderingly and very rapidly, and we have to be prepared. But many of us end up doing what? Defensive medicine and coercive healthism. You know, I mean, this is not surgical pathology, but how many of you have executive health checkups and health checkups? Do you know why so many health checkups are occurring? That's coercive healthism. I know I sound cynical, but it is. There are only 2% of all populations that are sick. And imagine the competition amongst clinicians and pathologists for that 2% of the population. Then somebody got up with this idea that there's the rest of the 98%, right? So why don't we look at the rest of that 98% and convert some of them into sick people? Yes. So, and that's what I mean, that the medical profession is metamorphosing into the healthcare industry. What's the difference between a profession and an industry? It is priorities, yes? Medical profession has its priority in service. What does the medical industry have its priority? Profit, yes? So it's your priorities that are different. And the market, that's the healthcare industry, and TATs, turnaround times, will rule our lives if we let them. But I would say belief in oneself is very important. Nothing else can rule your life. It's what you believe that you should do or you should be. And I would just say, to thine own self be true. We live in what they're calling the Anthropocene. You know, there are epochs. On one hand, you have Kalyug, yes, that is the Indian cycles of time. There are scientific cycles of time, and we call them epochs. And you can see them, Archean and, Proterozoic, and then Holocene, and we are in the Anthropocene. And this is what it is. 50,000 years it took for humans to reach 1 billion. 10 years it took to reach the next billion. Earth is now a human planet. We decide, and that's really what Kalyug is saying, huh? We decide whether a forest or a hill or a species will stand or fall. We make that decision. And are we capable of mature decisions, whether it is about climate change or whatever else, or even about our profession? Or are we Stone Agers? That means people whose brains haven't evolved, living in the fast lane. So I ask you this last question: where are we heading in the wheel of time? Where will we go, and how sensibly will we go into the next millennium? Thank you very much indeed.